So, what brings you in today?
Well, I'm having a bit of trouble hearing in background noise. I listen to a lot of live music.
After greeting the client, the audiologist's first step is taking a detailed case history.
Okay, and how long's that been going on for?
Probably about 6 months to a year.
The history allows the audiologist to elicit information about the patient's main concerns, their hearing and balance history, and other relevant medical background information.
Okay, and so you say you listen to a lot of music. Is
Yes.
that to do with your job or it's a recreational?
No, usually recreational.
Yep, okay, and so how often are you doing that?
This is a good opportunity to build a rapport with the client and to informally gauge the degree of a client's communication difficulties.
Yeah, that's great. So what we'll do is I'll just have a look in your ears for a start and then we'll get on with the hearing
Great.
test. Okay.
Important clues about some conditions that may affect hearing can be obtained through an otoscopic examination of the client's ear canals.
Good. And we'll just check the other one.
Otoscopy also establishes whether the patient's ear canals are sufficiently free of wax or other debris to proceed with testing.
Okay, so just through into this room here, we're going to do a tympanogram now.
Emittance audiometry is sensitive in detecting middle ear disorders.
Well, what we're doing is just checking how your eardrum is moving. So it gives us an idea of your middle ear function. So I'm just going to put this little rubber tip in your ear. You'll feel a bit of a change in pressure, but you don't need to do anything.
In tympanometry, the mobility of the middle ear system is measured while varying the air pressure in a sealed ear canal. Emittance audiometry also provides an important objective cross-check of the pure tone audiometric results. Now for the audiogram.
Here we go, just have a seat there. Here we go, so I'll just give you that button there.
Great.
So what's going to happen is I'm going to put some headphones in your ears and you'll hear beeps in one ear at a time. So whenever you hear a beep, you're just going to press that red button, even if it's very soft.
Right.
Okay? I'm just going to put these in your ears. These are right clipped onto your jacket?
Yeah, sure.
Okay, so it just sort of goes in your ear like a foam earplug.
The procedure for establishing an audiogram from an adult client begins with air conduction testing using pure tone stimuli. Headphones, or these insert earphones, are used to deliver the stimuli to the client's ears, one at a time. The client responds to the sounds they hear, usually by pushing a response button. The tests establish the patient's threshold of hearing for each of a number of frequencies that are important for understanding speech. The audiologist starts at an intensity level that's easily audible to the client. The level is then decreased in intensity by increments of 10 decibels, making sure the tones are not presented in a predictable rhythm or pattern until the client no longer responds. At this point, the intensity level is increased in 5 decibel increments until a response is obtained. This is repeated until the client has responded to 2 out of 3 ascending presentations. On the audiogram, the thresholds are recorded as crosses for the left ear and circles for the right ear. Air conduction thresholds reflect the integrity of the total peripheral auditory mechanism. It's not possible to determine the location of any pathology along the auditory pathway using air conduction alone. Therefore, If a hearing loss is detected, further testing is carried out using bone conduction testing to help establish the site of lesion.
All right, you're doing well so far. What we're going to do this time is put this headband on, and this little box just sits on the bone behind your ear. So all you need to keep doing is exactly what you have been doing. So just pressing that button whenever you hear the beep.
Sure.
This time you could hear it in either ear.
Right.
In the case shown here, the site of lesion is found to be the cochlea itself, rather than the middle or outer ear. Once testing is complete,
this man has experienced some blurry vision, which then became double vision, some pain in the left eye. Let's just check his eye movements. Follow my finger with just your eyes. And he has limitation of depression in the adduction of the left eye. Now we'll do a 3-step test. He's focusing on an object. We're going to cover and uncover. Keep looking at the object. And he has a right or a left hypertropia along with some exo deviation as well. Now we're going to have him look, turn his head, and it's a very large hyper. We'll turn his head to the right with his eyes looking to the left. And there's very little vertical deviation in this direction. Now we'll tilt his head to the right. There you go. And very little deviation. However, when we tilt his head to the left, we have another large hyperphoria on the left side.
I'm going to demonstrate the use of the diagnostic A-scan probe. It's important to know that this is not a biometry-only probe. This can be used for biometry, but it's also used for what's called diagnostic A-scan of both the globe and the orbit. This is a separate probe from the B-scan probe. Some units have a combined A and B scan probe in the same probe, and there's a vector display at the bottom of the screen. This is an independent display of the A-scan only. It's very helpful for quantitation, especially in the orbit, looking at muscles, looking at optic nerve, and in the globe for looking at tumors. So to measure things, to analyze internal structure, this is a very useful technique. I will demonstrate the basic probe position. Compared to the B-scan, there is no mark on the A-scan probe, so orientation of the probe doesn't matter. It can be turned any direction, and it's the same display on the screen compared to that of the B-scan probe. The patient has had a drop of anesthetic placed in the eye, and I have the eye open. I will demonstrate on the left eye, placing the probe at the 6 o'clock limbus, and then I aim superiorly, going across the eye to display the superior part of the globe. So even though the probe is at 6 o'clock, I'm displaying the 12 o'clock position in the globe. And as I move the probe, I angle it down towards the inferior fornix, and I watch the display on the screen. And the display, the initial spike is from the probe itself. I'm going through the vitreous here, which is usually a flat line because there's no reflection within the vitreous cavity unless there's vitreous pathology. And then I see the fundus spike, which is a high rising spike in the back of the eye. So my goal is, as I move the probe, I try to maintain this in a steeply rising fashion. I want it to be steeply rising, high and straight, which means I'm perpendicular. And perpendicularity is important for measuring purposes and internal structure analysis. And once I'm behind the initial retina spike, I'm in the orbit, which has many high spikes. So the contrast on the A scan is analogous to the B scan, where the B scan display in the globe is a lighter color, grayscale, because there's no reflection inside the globe. And correspondingly, the A scan display is a flat line. Once I get into high reflective tissue on the B scan, which is contrasted to the A scan, I see high reflectivity from the orbital structure. The orbit has many interfaces in it. It has muscles and fat, septa, and these give high reflectivity, so that contrast on the A scan. So as I angle the probe, I'm scanning the globe. I start posteriorly towards the posterior segment. The probe is almost pointed directly posteriorly, and I angle it superiorly more and more as I scan the retina towards the peripheral retina where the signal starts to break down. That means I'm here at the ora serrata area, and I can't get a good perpendicular spike. So I scan the globe comparable to the B scan in 6 quadrants. This is the 6 o'clock position. I then move over here in the left eye. This would be at the 4 o'clock position, and I do the same thing. I aim the probe almost posteriorly, and I get a spike from the initial signal, and as I angle it, I try to maintain the fundus spike in a perpendicular manner until I break down as I approach the ora serrata. I then go to the 2 o'clock position, do the same thing as I angle from the posterior segment more and more anteriorly to the peripheral retina. So by doing that, I scan the entire inner contents of the globe, and again watching the vitreous for any spikes in the vitreous, and watching the fundus spike for any low reflectivity of the fundus spike indicating a possible lesion such as a tumor. In this patient there's no pathology, so that's not demonstrated. I then can go to an orbit expansion, which simply has the same display in a more contracted view, allowing me to see the orbital tissue in a better display. And so as I go on the orbital expansion, I can do the same scanning technique. I place the probe inferiorly at the 6 o'clock position, and I am going superiorly, scanning the orbit. In this case, this is a superior orbit. So again, here's the initial spike from the probe. Here's the vitreous display, which again is flat because of no reflectivity. And here's the orbit reflection with many interfaces because, again, there are many different structures within the orbital tissue that give reflectivity. And I scan the superior orbit. You then place the probe again at the 4 o'clock position. And I'm scanning the superior nasal orbit. Again, going back and forth, trying to maintain perpendicularity of that initial retinal spike. I then can concentrate on specific orbital structures, especially the extraocular muscles and the optic nerve. And this allows quantitation of these structures, which is very important for following such pathologies as Graves' disease or myositis or other muscle conditions. And the optic nerve allows me to evaluate the nerve for swelling, as may be found in increased intracranial pressure with optic nerve fluid, or an example of a tumor of the nerve, such as glioma or meningioma, with nerve thickening. So to display the muscles, I again place the probe inferiorly to display the superior rectus muscle. So I'm going across the globe towards the superior orbit, and I watch the display for a little deflection in the reflectivity pattern. Because most of the orbit is low reflective, high reflective, I want to get a low reflective pattern indicating I'm probably in the muscle. So example right here, the muscle would be from here to here. So the muscle sheath, I'm going across the sheath from the inferior muscle sheath to superior muscle sheath, and I would measure that distance. We have electronic calipers and measuring tools to allow us to do that as we measure different structures. On this unit, I'm able to move the caliper and the cursor falls on the muscle sheath, and I then measure the other part of the muscle, and I display this as a thickness of the muscle. There are various tables indicating muscle thickness in normal patients. I'd refer you to that. Also, the textbook addresses that. But we measure the superior rectus muscle in this situation. I then look at the medial rectus muscle by placing the probe on the lateral globe, aiming nasally towards the medial rectus muscle. I move the probe back and forth. I make little microscopic movements, side to side, up and down, and I watch for a dip in reflectivity. And when I freeze that, I can see the pattern here of the muscle compared to normal orbit, which is high reflective here, high reflective there, but here you see the dip in the pattern because the muscle is more homogeneous than adjacent orbital tissue. Again, normal orbit is quite high reflective because of many interfaces. The muscles are more homogeneous than surrounding orbit. They tend to be a little bit lower reflective normally. So I can measure the muscle sheath here on the medial rectus muscle, placing the cursor there, and I get a measurement of the muscle thickness, 4.42 millimeters. So I can do that for the other muscles. Look slightly down. I place the probe superiorly, and I aim towards the inferior orbit to get the inferior rectus muscle, which is usually the smallest muscle of the extraocular muscles. And I watch the pattern for a slight dip in reflectivity. And I will use that for my measuring purposes. So right here, I put the cursor on this sheath of the muscle, the other cursor on that sheath, and I measure the inferior rectus muscle to be 3.64 millimeters. We then measure the lateral rectus muscle by placing the probe nasally on the globe. And again, we aim towards the lateral rectus muscle across the globe. We watch the orbital pattern for a dip in reflectivity and use that for our measuring purposes. So there to there would be the muscle sheath. We place the cursor on one side of it, then the other side, and measure the muscle thickness of 3.37 millimeters. So I measure the 4 rectus muscles. I can also measure the superior oblique muscle by placing the probe inferiorly temporally on the globe and aiming towards the trochlea in this part. The superior oblique muscle tends to run along the medial wall of the orbit, so it usually is further back on the display on the screen than the other muscles. It is more towards the bone. So right here is the superior oblique muscle. So I place the cursor on one sheath of the muscle, the other cursor here, and measure that dimension as 2.79 millimeters. So I've now measured 5 muscles, 1 oblique muscle, 4 rectus muscles. The inferior oblique muscle tends to run inferiorly, kind of in a hammock fashion, across the inferior globe. It's very hard to display that muscle. You have to get the probe way up here, the brow's in the way, and usually I can't display that muscle, so I don't usually attempt to, unless there's some question about pathology. Then I will attempt to do that. So that's the basic muscle measuring technique with the A-scan. Again, this probe is not a biometry probe. You couldn't do that kind of examination with a biometry probe. You have to use a dedicated A-scan probe to be able to do that. And also the size of the probe, as you can see, is much smaller than the B-scan probe, which is a thicker dimension. And it would be hard to place the probe, as I've done here, in different parts of the globe for that purpose. Now, to measure the optic nerve, I usually place the probe on the temporal part of the globe and aim nasally, and I attempt to get a display of the nerve looking right next to the globe display. The muscles, again, here's the medial rectus muscle over here, a nice display showing the dip in reflectivity. But I'm looking here more anterior to that display to visualize the nerve sheath spikes. Now sometimes they jump right up, sometimes you have to work going back and forth. My hand is moving little movements back and forth all the time, side to side, to try to maximize that display. And I see 2 spikes right here. You want to try to get steeply rising spikes. This isn't perfect because of this little artifact here, but I see a spike there, I see a spike there. So in her, I would measure from this part of the nerve sheath This is the anterior part, a medial part here. And the other sheath, I would measure here. So my nerve sheath is from there to there, measuring 2.36 millimeters, which is in the normal range for optic nerve sheath measurements. You can also measure the nerve from the medial approach. If you have a hard time temporally, sometimes the way the nerve kinks in the orbit, it's hard to get a good display. So I will then place the probe medially and aim temporally to try to capture the nerve there. And sometimes you can get a better display as you aim across the nerve going this way. So sometimes I'll go back and forth. I'll do on the temporal part first and then the nasal part, attempting to display the nerve. So here it's more difficult, so I had a better view by placing the probe temporally. So this is called the transocular approach. We're going across the globe to visualize orbital structures. You can also do a paraocular approach, where the probe is placed in a position to bypass the globe. Example here, I'm not going through the globe, I'm bypassing the globe to see the lacrimal gland, and I'm placing the probe in the area of the lacrimal fossa and looking at the lacrimal gland signal. And here it's the normal gland, so you see this kind of a step off in reflectivity as I go through the gland. If the gland's enlarged or reflectivity patterns are different, I can pick that up by doing this technique. I'll also go around in the different quadrants. So here at 6 o'clock, I will look bypassing the globe. So here's the globe pattern here. I want to bypass that, so I'll go more inferiorly, and I'll see the orbital display here. I'll go to 2 o'clock, 4 o'clock, and I'll show it here. I'll go to 2 o'clock and bypass the globe, showing here. I'm going to 12 o'clock and not showing the globe pattern, just the orbital pattern. I'm going to 10 o'clock, the orbital pattern here, and 8 o'clock, the orbital pattern here. So by doing that, I've done a paraocular approach to show the orbit, because sometimes orbital lesions are quite anterior, and they can't be displayed unless you show this kind of approach.
Is a very important orientation. It explains to us where on the B scan the top of the screen is oriented to the mark. So that, for example, if the probe marker were placed nasally to do a horizontal scan, we would have a nasal temporal scan. If the marker were superior, it would be a superior inferior scan. We'll begin by instilling a drop of anesthesia. Would you look up, please? A drop in the, close your eye, blot gently. Do not rub your eyes. You have a tissue to blot, but don't rub. Look down. I'll put a second drop. Look way down to your toes. That's it. Did it sting? No. Okay. And we'll start initially of our 4-quadrant exam with the patient looking superiorly, and the farther away the patient can look from where I place my probe, the more anterior periphery I can get with the sound. And that's what we need to see. So I start initially every single one of my transverse scans, either horizontal or vertical. We start by localizing the optic nerve. Once we know we've imaged the posterior portion, the optic nerve, then I will be sweeping the probe so that the superior aspect will be seen. Look way up high for me, please, with both eyes. So the marker is placed nasally. Sometimes you can feel it, you can touch it so that you're sure you're there. Make sure the patient's really looking at 12, not 11 or 10 or 1 or 2. And I place the probe on the inferior limbus, and I go straight back towards the optic nerve, which you see right here. Here's the optic nerve shadow. Once I see the optic nerve shadow, then I can sweep the probe, and you see the probe moving down, and the sound beam is moving up. Let me go back on the globe. Here we go. And the sound beam moves up until I start to lose contact with the eye, and you see the reverberations from the probe membrane. So I've examined the entire superior aspect from optic nerve in the posterior through about the equator, equatorial region, and then way out to the superior until we lose the image quality. Look down to your toes. Now the second exam for horizontal is of the inferior aspect. Marker again to the nose, patient looking down to their toes. Place the probe on the superior limbus, localize the optic nerve, see the optic nerve shadow? Occasionally you might need a little lower gain just in order to see that probe shadow more clearly. So there's the optic nerve, so I know that I'm always starting at the posterior. Then I sweep the probe up, but the sound is going down. I'm now at the inferior equator, and as I go farther and farther out, I start to lose contact with the globe. So that is the horizontal transverse of superior and the horizontal transverse of inferior. We'll do exactly the same 2 scans for transverse for vertical. Now the marker will be placed superiorly. I'll add a little more gel. Now I'm going to have you open your eyes and I'll have you look to the left. A little higher, see my finger right here. Most patients don't look where you want them to look when their eyes are open, and they certainly have a hard time when the eyes are closed. So that's why the majority of ultrasounds are performed on the sclera, unless there's a case of recent surgery, trauma, etc. So now you can see she's looking to the left, she's looking at 3 o'clock. I placed the probe vertically on the limbus temporally. There's the optic nerve again. So now this is superior, inferior, optic nerve. And I bring the probe out. There's equatorial. And all the way out. In fact, in this case, I get all the way out to her pupil. This is her iris and pupil. Because I have no nose, no eyebrow, and no bones in the way. And in this particular exam plane, I can get very anterior. It'll be a lot less in the next. Look towards me, please. Look right here. That's it. Actually, just with your eyes. That's it. Perfect. Again, the mark is superior. She's looking to the right. I place the probe vertically on the nasal limbus. I localize the optic nerve. Now, what's interesting is look how far I had to come to find the optic nerve in this last position. If you think about it, now that she's looking temporally, the optic nerve, which was medial to begin with, has now been positioned even more medial. I mean, it's way there. So I can't, if I go straight, I won't see the nerve. I have to come a little bit over the edge of the cornea to localize the optic nerve, but always start with the nerve. So again, there's the optic nerve. And now I bring the probe out this way, you see, going nasally, but the sound beam is being swept temporally, superotemporal, inferotemporal, inferior oblique inserting tendon, medial rectus, so you know I'm equatorial. I go way out until I start to lose contact by seeing the probe echoes from the membrane. And now I've examined all 4